Thank you, ma'am, for this opportunity. A rare but a potentially sight-threatening disease after trabeculectomy. The incidence is 0.2 to 1.5%, which is 10 times higher of all the intraocular surgeries cumulatively, for a simple reason that there is an open channel between the exterior of the eye and the interior of the eye, and that's what we want the aqueous to flow through. So the bacteria can grow from outside the eye to the inside. So that's why the incidence is 10 times higher than all the intraocular surgery put together. And of course, the immediate post-op, which is within 1 month, is comparable to all other intraocular surgeries. I think it's important for us to differentiate between blebitis and Bleb-related endophthalmitis, and it can occur any time from 1 month of the post-op period to the lifetime of the patient. So we have to keep a trap patient in our observation throughout the life. The risk factors are thin cystic bleb, mostly the mitomycin blebs, and of course the inferior and the nasal blebs. And it is a debatable question whether the bleb leak leads to the introduction of the microorganisms into the eye, or it is vice versa. So nobody knows, but we have to keep in mind that bleb leaks are very notorious for that, and mitomycin blebs are 18% of the blebs leak, and about 8% get infected in about 5 years' time. Other risk factors are constant rubbing, blepharitis, and use of steroids and diabetic patients and myopic patients. The pathogens are a little different from the routine endophthalmitis which we get in after cataract or any other intraocular surgery, and it is usually the staph epidermidis and streptococcus in 30% of patients, H. influenzae, E. coli, and Pseudomonas. So the type of antibiotic we have to use depends on the culture sensitivity of these organisms, and that we have to keep in mind, and that may differ. These blebs have thin epithelium, they are avascular, and there is a loss of the goblet cells if we are using mitomycin, and this goblet cells produce mucin, which is a sort of protective mechanism for against the microorganisms. So blebitis is a condition in which there is conjunctival injection, the bleb becomes milky and there is loss of translucency, and there could be an antechamber reaction up to moderate to not very severe reaction, but the vitreous is pretty clear. As against that, blood-associated endophthalmitis will have the involvement of the vitreous. These are all pictures of a blebitis. You can see that instead of being transparent, it has become milky, and you see a mild to moderate AC reaction with a small hypopyon in the last slide. As opposed to that, in a clear-cut endophthalmitis, it will be a picture in which the posterior chamber is also involved, and you can see the cells in the vitreous in the B scan. And this is a more dreaded complication. The management of blebitis is to start with. We can start with any of the fluoroquinolones, and we have 3 in our basket. We can use any of these. We can use fortified cefazolines, tobramycin, and vancomycin. They have to be put at half-hourly to 1-hourly interval, and even at night time. We can supplement it with cycloplegics and systemic analgesics, and even oral or intravenous antibiotics. If we get the response as we get in this picture, the blebitis has decreased in first 48 to 78 hours, then we are on the verge of winning the battle, and we can taper it down gradually. We can also try injecting of the antibiotic around the bleb, which works very well in certain cases. Management of endophthalmitis is more vigorous, and if we see cells in the vitreous, it is best to involve a VR surgeon in the management, and we can start with the treatment of blebitis. And the management pulse of endophthalmitis vitrectomy studies do not apply here, and we have to have an early vitrectomy instead of vitreous trap and injection of the intravitreal antibiotics. And it's a very good idea to have a VR surgeon with us. And it's a very good idea that the locus of infection is going from outside to inside. So bleb is the area where that locus is. So in more fulminant cases, we can excise that bleb area and put a patch graft. That takes care of the source of the infection, and the patient can have a quicker response. If you have bleb leak, it has to be managed as told by previous speakers. Again, I would like to stress here the use of mitomycin. It reduces the population of the goblet cells, reduces the cellularity, and produces thin encapsulated bleb which are tense, and they have a iron steel around them. So, I mean, it is very important to really titrate the dose of mitomycin, and 0.2 milligrams per ml for 2 minutes work very well. In my hand, you can choose your concentration upon your technique and the type of patient you have. Treat a larger area so that there is more posterior diffusion of the aqueous and it doesn't get accumulated in a small space, getting you a tight and very tense bleb which is likely to leak. Prevention is again the aim at an ideal bleb which is diffuse, not very thin walled and moderately vascular. It is very important to keep the patient into follow-up, and some surgeons even do a Siegel's test in every visit, may it be 3 years, 4 years, 5 years, 10 years old tabaclectomy. I do tend to do the Siegel's test whenever required, and early identification of bleb leak is important, and patient's education that report as soon as if you have some abnormal symptoms and stop rubbing the eye. And I think a glaucoma patient is never discharged from the care of the patient throughout the life, even if we do a trap. Thank you so much for your attention.